med-surg. We see different types of neurocognitive disorders in the young, middle-aged, the elderly, across all populations. So when we talk about neurocognitive disorders, we're talking about disorders that affect cognition, right? So that includes thinking and memory, ability to learn new things, speaking as well, and reasoning. So these are all characterized by a decline in cognitive function, and they definitely affect daily living. So we talk about, we'll be talking about delirium and then major and minor dementias. So our patients, as we know, are getting older and older because they're living longer because of all the wonderful things we have to keep them alive, right? Cardiac interventions and different treatments and medications. So patients are living longer, and we are seeing more and more patients with these major and minor dementias. So we'll be looking at that as well. So we're going to be focusing on this today on the causes and treatments and taking care of patients with both acute and chronic confusion. So acute confusion is termed delirium, okay? And chronic confusion are our major and minor dementias. So our chronic confusions most often occur in the elderly. Delirium can occur across any age. So we're going to learn how to accurately assess these patients, and then also how do we document documentation regarding this topic, regarding a confused patient. Can be very vague. And how do we best document? And then there are a lot of challenges with this in terms of keeping our patients safe. So safety is a key component. All right, so one of our student learning objectives is safety. So this applies to all of our content across our curriculum. Are you going to be able to identify key risk factors that are associated with delirium and dementia and a variety of patient populations? If you aren't able to identify the risk factors, that's step one, is how do we prevent it? Patient-centered care. You're going to be able to assess individual needs and preferences of patients with delirium and dementia, ensuring the care is tailored to their specific circumstances. And when we're caring for these patients, especially with dementias, we're also caring for the families, right? So caregivers, most often it is family. So patient-centered care does include the family as well. We're gonna talk about effective communication strategies with these patients. How do we talk to somebody and not make things worse, right? How do we keep them, if somebody is in an agitated state, how do we keep that from escalating and becoming a safety concern for both them and you? So we'll be doing a lot of things like that. Professionalism, right? So you're going to understand the ethical considerations in caring for patients with cognitive impairments, including respect for autonomy and informed consent. Okay, so always professional. You're always reflecting about your practice regarding any attitudes or any biases that you may have toward this population. When a nurse hears that they have a confused patient, what goes through your mind? And you want to kind of reflect on that and think about how that can affect your care. Teamwork and collaboration always. We work in teams. We work with, especially in these areas with dementias, we're working with case managers, we're working with the families, we're working with long-term care facilities. These patients go into short-term rehab, they're living at home, they have social workers involved. So there's quite the team involved with these patients. And looking at how we communicate with them and get across the information that we need to families and patients. And then evidence-based practice. If we don't have that foundation, we we lose the science of nursing, right? So we're always looking at better ways to do things, and there's always new evidence-based practice articles and studies coming out that influence our practice. So we're always aware of this. All right, let's start with confusion. So delirium is the acute form, and then we talk about chronic confusion, and under that we have minor, which is mild cognitive impairment, MCI. Has anybody heard of that before? Okay. So there's normal aging changes related to memory and thinking. We get more forgetful as we get older. Right? We have changes that affect our ability, like our speed of thinking and all different types of things. But when does it become what we call mild cognitive impairment? And then when does it become dementia, chronic concern? Our dementias are our major These are all characterized and described in regard to distracted behavior. These clinical features that are related to the onset. Was it a sudden onset? Was it a slow, insidious, progressive onset? Did this happen after a traumatic event? We're going to talk about amnesia. Okay, you can see this in the DVD. The course and the progression. So, did it occur slowly over the last 10 years at the time, very slowly? Or did it happen in a brief day of the night? Duration. So, did it last 1 to 3 days and then improve? Or is it lasting as little bit? And then we also describe it in terms of somebody's awareness and alertness. What's the difference between being aware and being alert? When I say somebody's alert, what's that? Their eyes are open, right? They are alert, they're awake, right? How about awareness? We talk about situational awareness. Are they aware of what's going on around them? Can you have a patient that is alert but not aware? For sure. So you walked into that room, the patient's eyes are open, but they are not interacting with you, they're not responding to you. We're also going to compare these. We look at DSM, so this is under DSM-5, and we're kind of categorizing it according to modest or mild, to significant major, cognitive decline, and one or more cognitive domains. One is complex attention. Are we able to keep our focus on something and complete a task? Or are we distracted? Do we stop doing what we're doing in the middle of it and we're doing something else? Can we have enough attention to complete the task? And executive function kind of looks at that task. So it could be something that requires thought and consideration of a number of things. Are they able to make a grocery list, drive and go to the store, purchase the items, come back and put them away? That's part of executive function. Can they balance and check things that they've been doing? Learning and memory, we'll learn that there is some credence to that. We can't teach them all new tricks. We lose a little bit of that ability just as part of normal aging. Language. So language is affected by these disorders, for both delirium and dementia. Perceptual motor. So it could include something like hallucinations, whether they be audiovisual or tactile. Sometimes we can see something, but we can't use it. And then social cognition. Okay, so being able to interact with your environment, recognize people and things, and be able to interact appropriately with others. And these can be with or without behavioral disturbances. And by that, we're looking at, so in a social situation, is somebody appropriate? Are they able to pick up on social cues? say things that make other people uncomfortable. Okay? So that's the behavior assessment. So this is important because we start on this. The first step in assessment of any type of confusion, whether it's delirium and dementia, and then what is this person's baseline, right? So who might we get this information from? The family, exactly. That's the best. So patients, obviously they're confused. They may not be the best person to get that information from. They may not be able to answer that. Right? They might think that you're like, what are you talking about? This isn't normal, right? So what is their behavioral baseline? So that gives us a foundation to look at their behaviors now and see how far are they from that. And are we expecting this to change, or is this just progression of disease? Neurocognitive dementias now exceed that of heart disease and cancer. That's pretty amazing. So we're spending a lot of our healthcare dollars on care of these patients. It's exceeding heart disease, which is just tells you the significance of the number of patients that are being. And then we're going to focus on some general documentation challenges for the nurse. Delirium. What are the symptoms? So with delirium, in comparison to dementia, it's very sudden. It can happen overnight. It can just be a sudden onset. It is reversible. It's temporary. There's always a cause. So we're putting on our thinking caps and we're trying to figure out what is the cause of this person's change in behavior, this confused behavior. Often they are inattentive. They might not be able to, you're not able to hold their attention. You're asking them your questions and they're not responding because they're thinking of something else or doing something else. They often have sleep disturbances. They might have their days and nights mixed up. We talk about sundowning. It can happen with delirium as well as dementia. We always think dementia is right, but with sundowning, we talk about that a little bit more. They might have disjointed speech. You might not be able to tell what they're saying. They might have a word salad. They might have a lot of different disorganized thinking. They might be disoriented to time and place or even person. Easily distracted. Impaired recent memory. They might be having hallucinations of the different types, different delusions. They might think they're the king of Egypt or their God. So they're all part of potential delirium. Fluctuating psychomotor activity. They can be hypoactive or hyperactive. So just somnolent and difficult to arouse, not doing much. Or they might be trying to climb out of the bed, they might be agitated, and be very, very hyperactive. Emotional instability, you're not sure what they're going to do next. They can fluctuate. They can become agitated easily. They don't seem to have much patience. So up and down with them, and very mobile. And then they might have some physical symptoms. Okay. So DSM-5 once again helps us in the early identification and the diagnosis. So the earlier we can identify that it's delirium, that this is a change, the earlier we can treat the cause. Okay, so we're always looking for the cause. This occurs over a short period of time, hours to days, and it can even fluctuate within the day. So you can have that variability of these symptoms. The predominant emotion with somebody with delirium is fear and a high level of anxiety. Impaired consciousness is a key assessment for delirium. What percent of patients that are in acute care that come into our hospitals, about what percent of those do you think have some form of delirium? All of them? Seems like that. Huh? What'd you say? 30? That's it. Approximately 30% of patients experience delirium in an acute care setting. Which type of patient? Would it be our OB patient, our psych patient, our post-op patient? So geriatric patient, but post-op patients also. And why do you think that might be? Anesthesia. What else are they getting most often? Narcotics, right, opioids. When you look up meds in your drug book, other than nausea, one of the most common symptoms is what? Is confusion. So keep an eye out for that. See if you really look at it. So there was a study. This was done at so there was a study on delirium in the ICU setting. So this setting held a high incidence of acute confusion with delirium. And they created an assessment tool for delirium screening that was recommended by the College of Medicine. And what they did, they screened it at admission and throughout the patient's stay. And they assessed several things: cognitive impairment, sleep deprivation, immobility, hydration status, vision and hearing impairment. And what they did in this ICU setting, they involved the family, and they did had certain interventions that they did in the ICU setting, and they were able to significantly decrease the amount of medications that were needed to treat somebody's delirium. Okay? Things like benzodiazepines. Okay? So the family would come in, or caretaker would come in, and they would stimulate the patient. They would talk to the patient. Okay? They'd reorient the patient. They would use memory cues for the patient. So they might put pictures in the room of family members, different things to cue their memory. But they made sure their glasses were on and they could see through them. And their hearing aids had batteries and were in. Okay, those are a couple of things we deal with. Increasing activity. So patients on mechanical ventilation, getting them up, is not only good for their physical symptoms, but it's also good for their brain. If they were on a mechanical ventilator, they attached to a vent, as much as they could, they put the patient on SIMV mode versus assist control, because SIMV mode requires them to take their own breaths, right? So it'll be a lower rate, and the patient will be breathing above it. Assist control you can do that as well too, but it assists the breath. It'll help support the breath. IMV will not. So they put them in a mode that allowed them to take their own breath. So those are, they also opened the windows if there are windows in the unit, and they did range of motion, and they stimulated the patient as much as possible. And they were greatly able to decrease from 26% to 8% the amount of delirium that was seen in these patients. And prolonged delirium, if you've got a patient in the ICU and they are in this delirium state for a longer period of time, the longer they're in it, the the outcomes they're going to have. So there's a correlation between prolonged delirium and death. Right? So if you're, and we can apply that to any place, right? Open your mind. Talk to your patients, even if they are confused, they're not responding to you, talk to them. Bring in family, have family, encourage family to talk to them, to do range of motion with them if it's nice, if it's appropriate. So what are the types of things we are looking for? So this patient comes in, they've got a change from their baseline, and we start looking at what's the cause, right? What we want to do is treat the cause. Nutrition, food, and electrolyte, and balance. For nutrition, history of alcoholism, what electrolytes, whether high or low, can cause confusion. Anybody know the food and lights really well? Sodium, calcium, magnesium. Yeah, those are the three main ones. Good. Dehydration state. Okay. A lot of the medications I mentioned, there's quite a few medications. If this is in an outpatient setting, or a patient coming in an ED, we'll ask the family to put all the meds the patient's taking in a brown bag and bring it in a brown bag test. Okay? And we go through all of the medications. So we're trying to rule out, if let's say we've checked all these other things, we're looking at the medications. And very often it could be a medication. Is there a new medication for it? Vitamin B12 deficiency has been researched as a cause of confusion in the elderly. We're looking, especially in the elderly, what is the one diagnosis that we're always checking?
UTI.
Yeah, UTI. Yeah. So it's one of the first things we think about in a good amount of time is the UTI. So it could be a patient with a pre-existing dementia living in long-term care, comes in your ED, and they've had Parkinson's symptoms. Now they're getting agitated. They're fighting with staff, and before they weren't at that point. Okay, so we're always looking for a cause. If there's a change, sudden worsening, we're looking for. So doing a straight cap, which can be difficult on a patient with confusion. They might be, agitated, fighting against you. So you're going to need some help. You need lorazepam or something to help relax them so that you can get a clean urine sample. UTI. You don't want to risk it being not be clean, and then we have a positive, a false positive, or a false negative. All right, anything that's going to affect cardiac output, right? So if somebody has some type of disorder and they're not perfusing, something that's affected their cardiac output, like heart failure, somebody who has a hypoxic event, respiratory distress syndrome, perfusion of our major organs, our brain can cause confusion. So we're thinking that could possibly be a cause. Hypothermia, I mentioned B12 vitamin deficiency. That can be also, this can be potentiated by diuretic therapy as well. So it's important to know these pieces together. Substance intoxication or withdrawal. So there's this patient coming in either under the influence of something or are they withdrawn. You're getting a rapid drug screen, you're seeing what their alcohol level is, what drugs are in their system, how long since their last use. And is this intoxication versus withdrawal? Medication use. So these symptoms can be vague. So you just kind of screen the patient, we do electrolyte panel, we will get hydration, we do a drag test, and we start ruling things out. Chest x-ray, is there an other, maybe it's not UTI, but it's some other infection. Maybe they have pneumonia. A good neural assessment, we can't figure it out, we're bringing psych in. Have you ever seen somebody with a psych consult because they can't figure out what the change is from? So psych will come in, they'll do their own investigation, they might go over some more tests or repeat something, and they're going to say, this is worsening dementia, this is new onset dementia, and they'll give their input. So read those consults. So how do we treat it? We can't give a drug and treat delirium. We need to find the cause and treat the cause. So that is the key, is to treat the cause. We do need to keep them safe in the meantime though, so we can treat symptoms. So if they're not sleeping, it's worsening their confusion, we're maybe giving them something to help them sleep. And grab some treat infection, analgesics if they're in pain, possibly lorazepam or benzodiazepine, or an antipsychotic like haloperidol or Zyprexa, that is to be indicated. Blood sugar is another thing, right? So patient, we're always checking the blood sugar. There's one specific class of drug that we want to be really, really careful with and confuse. It's a psych drug, an anticholinergic drug. It's also not just psych, it could be things like your inhalers, like Atrovent, that can also precipitate delirium. So that's one of the classes that we're going to hold in our dementia patients, anticholinergics. Usually doesn't have this question.
What was the name that you said?
Anticholinergics.
Of the inhaler?
Atrovent. So let's talk about documentation. How many of you have like received a report from a nurse and they have said the patient's confused? Okay, so what was next after that? Do they give examples? Sometimes. Okay, is it helpful when they give examples? Because what's the range of confusion? Somebody that doesn't know what day it is. She's somebody that's crawling out of the bed trying to climb the wall in your room, right? Or agitated and they're going to hurt you. So it's so important to describe the behavior when you're giving a report. What did you see that, that demonstrated that they were confused? Really, really important. If it's something that's new, you're getting a new set of vitals, doing a focused assessment for neuro and orientation. You're looking at all those things we've talked about, and checking the labs. And anytime that you document an abnormal, whether it be this or something else, you always need to document what was the intervention and what was the evaluation. Okay? What did you see? What did you do to keep that patient safe? And how are they doing? You're going to follow up throughout your shift. Every couple hours, you're going to document on that issue. Okay. So, for example, let's say this on March 18th at 8:20, you observed your patient. You come into the room. They were reaching into the air. They were mumbling nonsensical words in response to questions from this RN. Vitals, they were stable, they were documented. The neuroassessment, otherwise they look normal. If this is a change, it should be reported. Okay? So reported the change in cognition to the healthcare provider, and this patient, we find out, is on high doses of glucocorticoids. I hope that is wrong. Okay? We know, if you think back to endocrine, glucocorticoids long-term can cause a steroid psychosis, right? Patients can become confused. They can, you know how when you go on a steroid, you become elated and you get all this energy, but when you come down, you feel depressed. But if you're on long-term steroids, there is a risk for what we call steroid psychosis. So it's one of those things are ruling out. Okay, so this would be a medication-induced. So the patient's on there, the provider, and you might give a little tip to the provider if you think that that could be causing it. You can say they are on high doses of glucocorticoid. So you're checking the sugar for hyperglycemia, you're and ruling that out, and you're considering steroid psychosis. We see this that's not uncommon. Okay.
How long do they have to be on it?
Pardon?
How long do they have to be on it?
It can vary. It can depend on the patient's renal function, how they might be holding on to the glucocorticoid because they're not urinating. I mean, so many different factors. Yeah.
So, which one dementia you would bring that?
No, I mean, it's risk benefit all the time, right? So we're always, everything we do in medicine is the risk to the patient because there's side effects to everything and the benefit. Okay. So we might need to give it, but we're watching that patient first. And you're going to say, we'll continue to assess for changes and monitor the patient for safety. And I would say specifically, what are you doing, right? So I would say that alarm on patients on video monitoring, whatever you're doing to keep this patient safe. Right. And then the doctor comes by. If, you can always request the patient be seen if you think something's significant enough or they're heading toward ODS or they're possibly unstable and there could be a rapid response. So you can request that provider video monitoring in place. And this is a little controversial. We'll continue to monitor for safety. Have you heard not to say that? Say that? But that is what you're doing. You are continuing to monitor the patient. All right, let's jump into dementia. Dementia, by definition, in your text, is a syndrome of acquired, persistent mental impairment without impaired consciousness, so they are alert, caused by progressive neurodegenerative disease. And it's characterized by deficits in memory and eventually language. And those deficits are termed aphasia. Visual perception, and that's agnosia. The ability to organize thoughts and take action, executive function, and the ability to act out intentions. Okay? So you want to brush your teeth in the morning. Are you able to take all those steps? Use the, recognize that is a toothbrush. Put the toothpaste on the brush, brush your teeth, rinse your mouth, put it away. Okay? Apraxia, acting out the intention. With dementias, there are preclinical symptoms that can start decades before. But once symptom expression occurs, the lifespan is typically about 10 years. With symptom expression to end of life. Just like with endocrine and all the disorders, we talk about primary and secondary. Primary adrenal insufficiency, the disorders occurring in the adrenal gland. Primary dementias, where is the disorder originating? Occurring in the brain, right? So your brain is your primary organ for dementia. So the dementia itself is a sign of organic brain disease, such as Alzheimer's dementia. We'll talk about the pathogens behind that. Lewy body is a type of dementia where there's particular things going on in certain parts of the brain. Frontotemporal lobar degeneration, all occurring within the brain. So these are organic in the brain, primary. Okay. Secondary, you can think of some secondary causes of dementias, which I don't know. Would you say? Mad cow disease? Others?
Like a stroke?
Stroke? Yes. Vascular dementia? What'd you say? Alcohol, Wernicke's encephalopathy that leads to dementia. Parkinson's. Parkinson's, patients sometimes often end up with dementia. Down syndrome. After age 40, a good number of our friends with Down syndrome end up with dementia. TBIs. Boxer's dementia. Somebody who has repeated concussions from patients who play football, right?
So do they call it that, like, for instance, you said doctor's visit, and then like following up the QCE? Because obviously they can't diagnose it until they can actually go in.
Until
Right?
death.
Yeah, often, yeah. But they can, you know, a lot of these are diagnosed by symptoms, clinical symptoms. We look at CAT scans and things like that, but it's the clinical symptoms that really express the disease.
Would a UTI infection be considered secondary to?
So a UTI causes delirium versus a dementia.
It's just the infection of it.
Infection is a potential cause for delirium or acute confusion. Things like Parkinson's, Huntington's, vascular disorders are secondary for dementias. All right, so we've talked about these. So vascular, you have somebody who's having repeated TIAs, repeated strokes. That's who's at risk for vascular dementia. And this is the second most common type after Alzheimer's dementia. So treatment is going to be in prevention of TIAs and strokes, right? So our cardiovascular health. Parkinson's, 75% of people with Parkinson's develop dementias. And they're not quite sure of the pathologic overlap with dementia, but this low amyloid beta can predict whether they may end up with dementia. Amyloid beta.
Is that what they do as a test to see if there's
But yes, I don't know what it is. And then Huntington's is progressive. It's an autosomal dominant disorder, and we see choreiform, irregular, involuntary movements, and cognitive deficits. You do want to remember these, how they're, like, what are the causes of the TIAs, what was the Parkinson's, what was the Huntington's.
Can you say Huntington's again, please?
So there's a progressive autosomal dominant disorder where we see choreiform, which are irregular, involuntary movements, and cognitive deficits. And there's an effect on the frontal lobe that causes changes in behavior and personality with Huntington's chorea.
So did you say communicate disorder or the neurocognitive disorders?
That was specifically the Huntington, the choreiform changes. Or
Oh, you want to say neurocognitive disorder? All of those?
yes. Looking at matching. Frontotemporal, so we're looking specifically at that part of the brain. We see behavior and personality changes. Lewy body, they are found, they cause inflammation within the brain. We see visual hallucinations, sleep disorders. These patients are really high risk of falls. We see syncope with these patients. They are more functionally impaired than other types of dementia and have a shorter symptom onset to death. So it's 5 to 7 years instead of 10 years with Alzheimer's dementia.
Can they diagnose that with MR? Is that from these types of, are they diagnosed with an MRI?
You know,
Or is it based on their symptoms?
It would be a combination, it would be a combination, but symptom expression is like major with these. We do see changes on CT and MRI with these. Prion is Creutzfeldt-Jacobs disorder, and that is a small infectious protein particle that causes progressive neurodegeneration that leads to encephalopathy. And this one is rapidly fatal. So it's an infectious protein particle that leads to encephalopathy. There's no treatment for it, and it's rapidly fatal. We talked about TBIs, and then there's substance or medication induced, so exposure to drugs, medication, or toxins. So you might see something like this. You can use this slide to help you study. So what would be hypoxic destruction of the brain? That would be vascular. Class entangled, we haven't talked about that yet. That's Alzheimer's dementia. Hyperkinesis causing choreiform movements. Huntington's dementia. And then infectious particles called prions. Repeat concussions leading to brain injury, TBI, and then neuroinflammation, and that would be your TBI. Good. All right, let's talk about the caregiver for a minute. Okay? So, initially, when their loved one, their family member is diagnosed with dementia, often in the early symptomatology, patients are obviously have mild symptoms. They may know what's going on. They know what lies ahead of them, and the patient can get really depressed, knowing what lies ahead, right? As that progresses, they become less aware, and their depression lifts. There are obviously changes that we talk about, like lack of spontaneity and kind of a dullness. But the depression now goes to the caregiver, who's responsible often for 24/7 care for these patients, keeping them safe, helping them with ADLs, right? So there's a high burden that falls to our caregivers. And more than 4.5 million people in the United States are caring for people with dementias. And then there's the financial aspects, right? So billions of dollars, you don't have to know numbers, but billions of dollars for healthcare expenses for those with dementia exceeds that for heart disease and cancer. So there's a high burden of suffering for patients, their families, and society. So when you have that patient with dementia and the family comes in, you're not only caring for that patient, but you're also caring for those family members. And maybe the family doesn't come in, right? This might be the first time they might have had arrested for a long time from that patient. So we don't, when there's no family coming in to see that patient, remember that. This might be the first break they've had. So sometimes you hear a little bit of judgment, like, oh, nobody comes to see that patient. There could be, they might be needing a break, right? Respite care may not be available to them. So the caregiver is often described as the hidden victim. Right? They handle physical, social, and emotional consequences of disease. So depression is present in 20% with dementia, and then more than 50% of caregivers suffer with dementia. There are a lot of resources out there. There are, I know on the Cape, there's a support groups for caregivers. There are websites The ALZ.org is an incredible resource and website for patients, giving them information on what to expect, how does it progress, what are the stages, what can I expect? Are there respite resources out there for us? How do they keep their patients and family members safe? And when might they need to start making changes in their home setting to keep them safe? What do they do when they get agitated? What are the techniques that nurses use to redirect them? Or they need to learn all of those things as well. All right. So it's saying that I can't play my video on this, but I'd like you to watch that video. It really describes Alzheimer's dementia. There are a lot of theories as to what can cause dementia, but the most common and supported theory, it is not multifactorial. A number of things can contribute to dementia, from our environment to nutrition to hereditary factors. There are 4 genes that are associated with different stages of dementia. 1, 14, and 21 as our trisomy 21 and Down syndrome patients with early onset. And then there are 19 genes for late onset. So there's a disclaimer, it cannot totally be explained by genetics, so it's multifactorial. Head trauma is the greatest risk if other risk factors are present. So with Alzheimer's dementia, if you watch this video, it talks about the plaques and tangles theory. There is a Alzheimer's, it's named after the doctor who discovered it. A biochemical abnormality of acetylcholine. So it was first coined in 1976. And there's an enzyme, choline acetyltransferase, that was reduced by 90% in the hippocampus of patients with, and the cerebral cortex of patients with Alzheimer's dementia. So a significant reduction in this enzyme. And this enzyme is required to produce acetylcholine. So if you're asked about that, it's acetylcholine that is dramatically reduced. As we age, we normally start losing acetylcholine. So this is important to remember that, because a lot of our meds act on acetylcholine. We have our acetylcholine, we have our inhibitors, right? So we'll talk about that in a minute. But if there's not adequate acetylcholine, a lot of times these meds are not going to work. Right? These are meds that we start on when we first are diagnosed with Alzheimer's dementia, so are mild and moderate stages. So the enzyme is choline acetyltransferase, known as CAT. And that is the enzyme that's required to produce acetylcholine. Acetylcholine is responsible for functioning of the hippocampus, so there's a major contribution to memory with acetylcholine. So it's the primary neurotransmitter for memory and thinking. There are some other neurotransmitters, things like norepinephrine, serotonin, that are responsible for some of the behavioral changes that we're going to see, but it's acetylcholine that's most important with this disorder. Another biochemical abnormality is glutamate, and that leads to overstimulation of something called NMDA that leads to increased intracellular calcium. And that extra calcium, just like it's bad in our vessels, it's not good in our brain either. And it's calcium that causes plaques and clumping of what we call these neurofibrillatory tangles. So as that impulse travels from axon to axon, it goes from the axon down the dendrite, and then it crosses that gap to the next axon. So the transmission of impulses, if there's a lot of calcium buildup there, it slows the impulse, and that's why we see decreased slow thought process, why we see slow movement, because the impulse generation and speed of the impulse is affected. Patients with Alzheimer's dementia have a high number of plaques and tangles. Plaques lie in the spaces between the neurons in the brain. And these neurofibrillary tangles clump together inside the neurons and cause the brain cells to twist and die. The video, I would watch that video. It's nice to see the video of it, so it sticks in your head. It's very, very well done. They're from Alzheimer's.org. So the plaques and tangles are also going to block normal transport of electrical signals. So we talked about the symptom expression, but we also look at things like CAT scan. So in my patients with dementia, I like to pull that up, and I like to see how much brain atrophy there is. So how far advanced is my patient? When you look at a CAT scan, you can see that it says that there's reduced surface area of brain matter. Okay? So you see a smaller brain. So those are characteristic of late stages, so brain atrophy. In the office, somebody who is skilled practitioner, often these patients who they suspect might have dementia, they go to a neuropsychologist, and with 90% accuracy in the office, they can diagnose dementia. Okay. So
Is that when they do like the tests, like the clock and
many of status
all that?
exams, yep, there's several tests that they do. Alright, so here's our timeline of our life from birth to death in our 80s. What we see is healthy aging that occurs over time, so here's our 40s. I mentioned that even several decades before, there can be some changes going on in the brain that predispose you to Alzheimer's dementia. So in our 50s, we can have what's called amnesia. That term, mild cognitive impairment, what we call a minor dementia, right? It's categorized under that category. Other cognitive functions are okay. There are some memory problems. The next slide can give some examples. The brain compensates for changes. And often these people with MCI, they go on to just have normal aging changes, memory issues and things like that, just normal age-related memory loss. But then there's a percent of those who start to then progress on to focal dementia. And typically in about 10 years, from symptom expression to death. So as we age, just like with our renal function, where we have decreased functioning cells, we have decreased functioning normal. This is normal, decreased number of functioning neurons. So this is where it's hard to teach an old dog new tricks comes in, because if that's true, as we age, we are not as able to learn new things, learn a new task, take up chess, and things that we haven't done before. Okay? you quickly reorient yourself. So if you were somewhere, and for a minute, or get where you're at, but then you reorient yourself. And you're joking about it. You're forgetting things, so you can make jokes. Mild cognitive impairment, it starts happening more frequently, okay? So maybe now you are parking in the same place every day because you know that sometimes you forget where you parked in the parking lot. You're having more difficulty using the right word. You're temporarily becoming lost more often, trouble understanding a map, but you figure it out. And we start to worry about it, and then it's somewhat noticeable by those we live with or that are close to us as well. With dementia, examples, we forget what an item is used for. So we pick something up and we're not sure what to do with it. We use the wrong word, we start substituting one word for another. We become easily disoriented or lost in familiar places. You go to your walking route in your neighborhood, and an hour later you come home and it was a 15-minute walk. Little or no awareness. We start to lose awareness of the fact that these are changes. So initially, we'll talk about the stages. So in mild AD, we start seeing things like personality changes, right? So somebody who was like very social, now all of a sudden doesn't want to go out. So they keep their calendar without anything going on. Or somebody who's very, very outgoing becomes more quiet. They're still functioning independently. They drive, they go to work, they're part of social activities. They feel that they might be having memory lapses, forgetting the familiar words, or the location of everyday objects. So it isn't somewhat noticeable for friends and family. Forgetting material that one has just read, and that can also be stress related. So a lot of some of these things, like you think, gosh, I think I have my OCD. It could be the amount of stress in your life, right? You guys are in nursing school right now, so you might be a little bit more forgetful, or
I think I have this right now.
So moderate. At this stage, damage is spread to areas of the cerebral cortex that control language, reasoning, sensory processing, and conscious thought. So you can start to see a little bit of shrinkage on your CT. The sulci between the gaps between the areas of the brain enlarge, making it more difficult also for the neurons to travel. And signs and symptoms of disease become more pronounced and widespread. So it's in this moderate stage that you have to start thinking about safety. Right? So this is really important that they have, your family members have resources available to them. What do they need to do to help these patients safe, wandering? They can have more personality changes, things like become agitated more easily. Do these overlap a little bit? Definitely. So just be aware of that. And some days are better than others, right? So you might have a good coherent day and then a poor day the next day. So more intensive supervision can become necessary for the family. The patient often starts going into the denial. So less awareness that they're not forgetting that they have a problem, which can become a problem itself, okay? Because they may be impulsive, they might have poor judgments. So at this stage, they might go online and give away their life savings to some important community resource. Didn't try words there. All right. All right. Increasing memory loss and confusion, short attention span, inappropriate outbursts of anger, problems recognizing friends and family, difficulty with language, problems reading, writing, and working with numbers, difficulty organizing thoughts and thinking logically. They can't relate things, these are unexpected situations, and they have restlessness, anxiety, and wandering, especially in the late afternoon and night. So this is when some yelling occurs, right? So I mentioned that can be with both delirium or dementia. They might become more suspicious of people and things going on. They may be having delusions or compulsivity. You might see repetitive like behaviors like wringing of their hands, tissue shredding. They might need help choosing proper clothing for the season or the occasion. So what are some ways that we can keep these patients safe at home? Everybody familiar or work with patients with dementia that you can share some of the things you've learned?
And anything from like bed alarms
Yeah.
to let the caregiver know that the patient's getting up. Door alarms,
Door alarms, and where do they put the door alarms?
way up high.
Way up high where they can't see them or anything?
Even like a child safe, like a cover
Yeah.
for a doorknob.
Yeah.
It's too hard for them to figure out.
Baby gates for the stairs,
Baby gates for stairs.
remove the rugs, because a lot of them are safe. Store locks.
Like a rail. Okay, so all the things to help.
Kind of like tar
Or
road.
like putting marks on the door, like black marks that you can make when you never give them time.
We put alarms on all the windows and doors that when my father-in-law had it, just to,
Yeah, so alarms, so if somebody's trying to go out a
Yep.
window or a door at night,
yep.
an alarm's gonna wake you up. Yeah, that's really important.
Cameras.
Okay. Trying to, oh, here it is. All right, so let's give some examples of some of these, because you will be asked to identify them. How are we doing on time? All right. So I talked about some of the things in the terms. So you need to be able, yes.
Sorry, can you take a 5-minute break? Is that okay?
Yeah.
I just wanted to run to the bathroom, but I want to listen to you.
Yeah, okay, we can take a 5-minute break. So let's do that right now. So what time is it? At the same time, they help that patient in the car and go for a drive. It just shows the commitment that family, gives to try to keep these patients safe. Wandering can't be a problem. The Alzheimer's.org estimates that 60% of patients will wander and become lost in the community at some point. And unfortunately, there are a number of those who end up being either exposed through exposure, environmental exposure, or they get hit by a car or lost in the woods and don't make it. There was a gentleman a few years back, it's been like probably over 10 years now. It was, I remember really what happened. I remember reading about it. The patient and the wife was following the patient, the gentleman home. The patient went right instead of left out of the Toyota dealer, the car dealer, and ended up, they got lost out in the community, and they found that gentleman way down in Wellfleet on somebody's back porch. Remember that? There wasn't there, and he died from exposure. The car was right in the lot. They don't think to get into the car to get out of the environment, and he was found on somebody's back There are the police officers, community education, what to do when you find somebody that you think might be out there lost and wandering in the community. Nursing homes deal with this every day, patients trying to get out, they have all types of alarms and locks on doors. There are assisted livings and nursing home centers that have created whole little village of an environment for patients to go out about, just like they are out in their community, but it's in a close space. I know there are some dementia centers here on the Cape. I'm not sure if they offer things like that, but would love to see more and more of those for these patients. So they can go to the cafe, they can go to the post office, but they're safe within this enclosed area. So there's something called the Safe Return Program. The medical alert bracelet is important to wear. You see tags on their clothes that have their phone number, things like that. So you can register in their resources for the 24-hour helpline for patients. This nursing home decided to switch their days and nights, so they, for patients who were constantly up at night and slept all day, so they have the night staff became the day staff and they swapped them. So what are some of the theories of this? Disrupted regulation of melatonin could contribute to this. Disturbances in their REM sleep, deterioration in the hypothalamus. When we have a patient who starts to show some agitation, they start to get restless, what are some of the things that we offer or can do for these patients who might be becoming kind of restless? And
Redirect them.
redirection, okay. Can you give an example of that?
I just would change their minds. I had one person that I ran a dementia unit for a while, and sundowning, one lady would wait for the bus every night, and she was very adamant on waiting for her children to get off the bus. We put up like a stop sign and things for her, just to kind of, you have to go into their world kind of, and then go from there. Everybody's a little different.
Right. Are we gonna tell them?
No, absolutely.
You're not gonna reason with
No.
them, you're not gonna try to change their mind, right? Just, you gotta picture her brain. And there's a redirection video, that I'm gonna have you watch on your own as well, that gives some really good examples. And it actually, there's a part of the video where they look at the, a post-morbid brain, and it shows how much the brain has shrunk, and the sulci increases, and really seeing that is helpful for me, because I think of that when I'm trying to talk to that patient and remind myself they're not going to be able to reason with it, right? I'm not going to push them. You're not going to, when you're giving meds, you're not going to make sure they say their name and date of birth, because they're not going to be able to, right? So you're going to rely on them at the end, or you're going to have a family identify them as well. So that's a good example. What could be, are they able to tell you, as they get to the moderate and later stages, they really cannot tell you that they have to go to the bathroom, right? Or that they're hungry, or that they're cold. So they just get restless, or they get agitated. So we're going to offer, we're just going to say, let's get up and go for a walk. Oh, look, let's go to the bathroom. Let's try to, have them go to the bathroom, see if they have to go, because they can't tell you that. Offer food.
It always amazed me too, because I worked with people with dementia for a long time, where their minds do not know what they're supposed to do when they get to the bathroom with their bodies moved.
Right. Or
So,
they freeze. That's,
yeah, so you would just have to try to distract, and then, pants and sit them on the toilet and they knew what to do. But they wouldn't know why they were in there like mentally, with the body?
So would that be an example of aphasia, executive functioning, apraxia? That is an example of apraxia. Okay, so they are not able to put things on in order. So they might put their shoes on before they try to put their pants on. Okay? So they, or they might come out of their room and have over their gown, mismatched shirt with pants that don't go together at all. Or their shirt on backwards. Okay? So that would be an example of a praxis. I'm going to talk about each of those briefly right now. Other symptoms of apraxia include they stand up and then they freeze. So they stand up and then they just takes a minute for them to figure out what they're doing. They can't initiate walking right away. So you kind of have to take them by the hand and help them move forward. Trouble drawing a simple picture like a circle or a house. They're not able to do that. They can't set the table properly. Okay? So they, leave stuff out or they put things in a different order. They're not able to wave goodbye to people. So what are some things that we can do to help with apraxia? So in terms of helping them get dressed, like what would be some things that you might do, anybody that's worked with dementia patients?
Have them so same thing all the time.
Yeah,
You know,
routine,
Yes.
they
Not just
definitely
the
get
activity, but like the time and place.
Yeah.
You know,
Yeah, so doing things at the same time each day is helpful, having a routine.
subconsciously what it is what to do without it being formal. If that makes sense.
Putting the clothes in order out on the bed.
Lay out the clothes in the order they put them on. So the shirt would go, or the underwear would go first, then the shirt, then the pants, then the socks, then the shoes. So you're gonna lay everything out in order. So you don't have to. Step-by-step instructions for something, maybe pictures of what to do. Adaptive utensils. They might have, all their buttons are off, so you want, there's some adaptive clothes that they can wear, maybe no buttons. Are you gonna rush them when they're trying to do this stuff? You're in a hurry, you've got 5 other things you gotta get to. Just like doing medicine and NG2, this is something you do not rush. You don't rush people with dementia when you're trying to get dressed. The gentle encouragement and patience. Okay? All right, so let's talk about executive function examples. So I did give some already. I talked about balancing your checkbook. So they have trouble planning and organizing tasks. It's following through. They start something on the stove, they go in the next room, they forget about what's on the stove. I did this last week. They have difficulty preparing that shopping list and then going to the store, getting the items, coming back home in a way. They have trouble estimating how long a task will take. So you're on the phone with them, and they say, well, I'll be over in 20 minutes, okay? They don't come see you for an hour and a half, okay? So they have difficulty estimating how long something's gonna take. So obviously this is if they're still driving and.
So this is more like mild?
So no, this is more, you'll see beginnings of it,
Okay.
but more moderate.
Okay.
They can get overwhelmed when there's more than one across one step. So multitasking is very, very difficult for them. Talked about poor judgment in terms of like impulsivity with financial decisions, giving away their life savings, purchasing things they don't need. Spouse comes home and there's all this stuff that's been delivered from Amazon that they don't need. The remote doesn't work. So what would you do?
You're back.
Check the batteries, you're gonna turn off the TV, turn it back, so they can't do that, they can't troubleshoot, right? They bring it how to do that. Okay, so those are all examples of executive function. And then, under that, in terms of social, under executive function, they are unaware of social cues. So you can bring them to an event, and this can be really, really hard for family. Anybody watch Still Alice?
Mm-hmm.
So she was brought to something. I would recommend this movie. You can watch it. Still
She had
Alice.
early onset, yeah.
And they bring her to, the daughter had some event or something, the adult daughter was doing some performance or something, and they brought Alice, who had early onset dementia, a brilliant woman, neuropsychologist, and just completely inappropriate in the social situation. So made everybody uncomfortable, right? Because they don't have the social cues, or something difficult like she meets the daughter comes out after the wedding, and she doesn't recognize her daughter. Right? So, all right, aphasia. So let's say I'm up here talking, and I pause all the time, pause frequently, or I stop using full sentences. Okay. I can't finish a sentence, or I'm word searching a lot. I'm using incorrect words for things. Or I start rambling. It made no sense. What is it? Let's say I make up a word, or a word that I'm trying to use. What is there's a term for that?
That word sounds
Begins
or
with an
something?
N. Word salad is when you mix a bunch of
Jumbled it
words
up.
together that make no sense. Begins with an N. So I say, let's say I want to mention that dog over there, and I say, just make up some word. That's called a neologism. So neologism is when you make up a word for an object. I can use the term cat for the dog, so I'm replacing the word with it. I have seen patients do that for sure. They'll call something different. So those are all related to language and speech. So aphasia. And then there's agnosia, Agenosia. And an example of that is when I see a hairbrush, but I don't know what to do with it. I look at it, it looks familiar, I don't know what it's for. The doorbell goes off, I don't get up to get it. Phone rings, I don't get it. I don't put it together that the phone is ringing. I don't associate the phone with the sound. These patients have a hard time telling you where their pain is. So when you're assessing them, and they have dementia, and you say, are you having any pain? Are you going to rely on what they say? What are you going to do instead?
Assist them and look for patients.
Nonverbal, yeah. So you're going to look for grimacing, you're going to look for increased heart rate and increased respiratory rate, agitation. So they can't express that they have pain.
What's that, there's
patients with dementia specifically?
Yeah, we used it in psych.
Yeah, it's
I forget, it doesn't matter.
So it's probably flat. No, it's not flat.
All right,
If somebody has dementia, they ain't gonna.
all right, so symptoms of severe, so this is progressive, so it's now you're like 7, 8, but that can vary, right? Late stage AD, there are some scales, like there's scales where there's scales under the mild, scales under the moderate, but for us, we're just talking about mild, moderate, severe, late stage, where the plaques and tangles become widespread throughout the brain is atrophied on CAT scan. This progresses to end of life eventually, right? And the patient pretty much can become bedridden, completely dependent, incontinent, and eventually will reach end of life. But beginning of these, they are unable to recognize their loved ones or communicate in any way, so they are nonverbal and completely dependent. They're not eating well, so you see weight loss and muscle atrophy. Seizures are not uncommon in infections. They have difficulty swallowing, or dysphagia. They may groan, moan, or grunt. They're sleeping a lot, loss of bladder and bowel control. So it's very sad as they progress.
Would these patients at this point be on CMO?
Yeah. We hospice care. All right, so let's talk a bit about some of the medications to treat dementia. The first set are what we call cholinesterase inhibitors. So we talked about that CA2, the enzyme, and when you give a cholinesterase inhibitor, it's going to help prevent the breakdown of acetylcholine, which is important for memory. So, as we age, we lose acetylcholine. Okay, as dementia progresses, there's less acetylcholine available. So, you're going to see these meds in early and moderate stages of Alzheimer's dementia, with the exception of Aricept or donepezil, and that's for mild, moderate to severe. So you will see it's in all three. But these are going to work. These aren't curative. Is Alzheimer's dementia curative?
No.
Is it able to be cured? No. But what are these meds going to do? They are going to hopefully help them maintain their functioning later, add months to increase function for the patient, so the ability to do their own EDLs, to have fewer symptoms, symptom expression. It's not curative, but it can delay the onset of later stages. Carry activities, maintain some thinking, memory, speaking skills, and can help with certain behavioral symptoms. All right, Razidine, or Lanthine, Exelon, or this Stagadine, and Aricept are cholinesterase inhibitors. And then there is Memantine or Namenda. And it is a N-methyl aspartate receptor antagonist, and it's used to treat moderate to severe AD. So another way to kind of tell what stage your patient's in is to look at their meds, and if they're on the Namenda, I know they're later stage, they're moderate to late stage. So Namenda is going to work by regulating glutamate, and that's that neurotransmitter that involves memory function. And it's that glutamate, we talk about how it causes an increase in the calcium that causes the fibrillary tangles and the plaques to build up in the brain cells. So it's going to delay the progression of some symptoms from moderate to severe. Also, it's gonna help maintain function, maybe using the bathroom independently for several more months. They work very differently from cholinesterase inhibitors, and they're often used in combination. You may see them together. I see Aricept a lot, so you're thinking, mild, moderate. It can be with severe, it's the one cholinesterase inhibitor that can go into severe. And it's given in combination with and there's a combination drug for it. It's called Maxeric, and it has the cholinesterase inhibitor along with the NMDA receptor antagonist. All right, so we're going to, are there any questions about dementias? We're going to talk about another disorder that falls under neurocognitive. Okay, all right. So, amnestic disorder, there are 3 types, but this is a pathologic loss of memory, where an area of experience becomes inaccessible to conscious recall. Okay. So there's a period of time that you can't recall. Okay. Or it could be anything prior to this point in time. So they don't recall anything from birth to this point in time. Dissociative amnesia, there's 3 types, is the inability to recall important personal information, usually of a stressful or traumatic nature. It's too extensive to be explained as normal forgetfulness, and is not substance abuse or because of any condition. Okay? What's key for this is the stressful or traumatic nature. I've seen this in the ED. Years and years ago, a patient who was brought in was in the shower. They got in the shower that morning. When they got out of the shower, they couldn't remember anything prior to that day. That person was getting ready to attend the funeral of their brother. So that was the traumatic event. It could be child abuse, or neglect, or some traumatic experience in childhood. It could be kidnapped. It could be the loss of a spouse. A number of different stressors. An accident. So you don't have to know these for the exam, but just be aware that this surrounds a stressful or traumatic event.
Do they ever get it back?
That's a good question. So, that patient, that's one bad thing about working in the ED.
You don't know, I know.
But, so for that person, I'm not sure, but they may or may not, so it's a waiting game. And this can be really, really difficult for family, because this person now that they spent their whole life with,
I know
doesn't
that.
remember, right? So, anybody, what is the movie with Drew Barrymore?
Oh,
with,
yeah.
the second time.
Yeah.
So he forgets everything after 10 seconds. So that was an example of an amnesia that related to her hitting that tree.
It's kind of like an amnesia type of a
It
thing.
is, and that's
Yeah.
amnesia. It is,
Huh.
So, do they have any sort of like
Treatment?
No, physical factors. I know it's caused by stress or trauma, emotional trauma, but
It's
no
purely
physical.
memory.
Imagine that.
It's probably a different.
I didn't know your kids. I know.
Yeah, there could be, like an accident, right? So that would be traumatic, that would be, it could be a physical trauma. That's what you're asking?
Well, no, even if it's stress induced, like, is there some sort of physical attribute to it, or is it all just
It could be
neurons?
purely emotional stressor. So these are some examples of some of the stressors. So number of different things. You can have amnesia from alcohol, right? Somebody gets totally drunk, can't remember a period of time, right? It could be substance abuse, somebody spilled something in your drink, okay? Which is becoming more and more common these days. Medications that you're given in the hospital, opioid analgesic. And then there's certain toxins that can All right, so here we have this gentleman, here in the ED. This is like a very common scenario. Husband or wife, so the wife brings in this patient. They put the patient into a room, you go into the room. The wife is reporting worse communication, is agitation, urinary frequency. So you're going to go up to that patient and you're going to say, Mr. Thomas, are you okay? What is your name? And so right away, what am I doing that can not be a good idea? So I'm talking a little bit about this, he's probably hard of hearing, so he'll scream at me. What else did I do?
Touch them.
I touched you, and I'm asking you questions that you're not going to be able to answer, right? So you're going to get really frustrated. So how might I approach the patient?
Eye to eye, right?
So I'm going to make sure that the spouse stays with the patient for one day, right? And I'm going to come in and am I going to lean over her and say, I'm going to get down on this level. And I got to be careful because he is agitated, I know that. So pretty hard. Oh yeah, patients with dementia can hurt you. Right? They can squeeze your hair really hard, they can pull your hair, they can grab that necklace, right? They can grab your earring. That's why you don't wear those earrings. So he's like, don't touch me, you can yell, and it escalates from there. It can escalate to the point that we have a catastrophic, what we call a catastrophic reaction. This happened to me with a patient who had come in from a nursing home. They were on a stretcher. They were in the hall because we didn't have a room. Plus, we wanted to keep an eye on her. With the spouse, taking care of the patient with dementia, and brought her in because she was more and more agitated. He could not, as much as he wanted to, he couldn't. She was unsafe. He didn't know what to do. So we brought her in. So, we tried to figure out if this was a delirium on top of the dementia. Okay, so getting that straight calf, which was interesting and difficult to do, right? Checking labs. So, and trying to keep this patient calm, right? Because the patient was yelling out, causing a lot of other patients to look and screaming like we're hurting her, things like that. So these patients, I have walked with these patients around the unit, given them face cloths to fold, right? So you give them something to do with their hands. But I made one mistake. This patient was going to be admitted. The patient, I did not use that word around the patient because we knew that she wanted to go home. And I had talked to the family member aside a little bit of ways. She had such good hearing. She heard the word admit, and it was one of the worst catastrophic reactions that I've seen in somebody. It was so difficult to watch the reaction of the spouse. The spouse just, because we had to keep that patient safe. That patient heard admission, they became extremely agitated and trying to get off the stretcher. We had to sedate the patient with medication. And just extremely difficult for the husband. Okay? So I did not feel good in the day, right? So, these things happen. We try to do everything we can copy something I said, if it's speech, I'm there, right? Bring a third party in, so it's a third party technique, somebody who they haven't met yet. Bring the clinical leader or somebody else in to try to talk to the patient, to try to get that patient to take their medication. So that's one thing you can do, and that often works. Or maybe there's a CNA that has really clicked with that patient, bring them in, okay? We can redirect them. So this is a really good video. It didn't allow me to post it on here, but you can click on that link, and it goes through the techniques for redirection. So let's say, so let's go for a walk, or you see a picture of their family member in a room. So tell me about this person. Sometimes, and it's very common that their long-term memory might still be intact. It's the short-term memory that is the first to go, but they might have some pieces of long-term memory. They might be able to talk about, or maybe they just make something up, but it redirects them off of whatever makes them upset. And this is after you've offered the bathroom, taken them to the bathroom, offered them food.
Music works a lot, I think.
Pardon?
Music.
Music. So music and memory is I don't know if you've heard of that.
They'll sing it even though they won't know anything, but they'll just
Put on, and what's key with music is that it's music that means something to them. So there's this program called Music and Memory, where you, and especially in dementia units, you create a playlist for the patient, and you put headphones on, and you let them listen to music that speaks to them. You'll have these patients who might not recognize their family member or be able to put a sentence together singing along. It's some reason music and words and songs sticks in these patients' memories. And it can not only help them with their speech strengthen, but you can have a period of clarity after they listen to this music. So if they're having that, bring the family in, and they might recognize them for the first time in weeks or something. So music can really make a difference. So I use that a lot, like I work a lot in the psych part of our ED, and I bring my phone, I find out what music they like, and I put it on. And it can help. Validation therapy. So they see somebody in the room, and that person's going to okay. So we don't want to just totally dismiss it, oh, nobody's there. Because to them, it's very real, and somebody's there, and they're going to hurt them, right? So we can use redirection, but we also want to validate that they see that person. So you're not going to say, no, nobody's there, don't worry about it, because they're going to worry about it, and it can escalate their behavior if you're not hearing them. So you do want to acknowledge that you hear them, and you're going to look under the bed, you're going to check the closet, and you're going to say, everything looks clear, and let's do a puzzle together. Let me set this up for you. So you're going to validate where they're coming from, and then redirect them. So those are just little things you can do in clinical and med surg, and you're going to see these patients and get to practice some of these things hopefully this semester. How are we doing on time? It's done. What is it?
It's 10.
2
minutes to 10.
So this is ALC.org. Alright, so click on that real quick. Some of these you're gonna wanna look at. Can you pull these up? If you clicked on this, can you pull these up later? No.
Yeah, these can be posted on the website, but just in case we don't get
dosage, right? An MDA. And what is the mid to moderate? Is your cholinesterase inhibitors, right? Taking longer than normal to accomplish tasks, that would be mild. Sometimes this places glasses, keys, or other items. That's normal, right? And then sundown typically begins with moderate. Okay. All right. How did you do with that one? Bad? Bad? Sure. Which of the following typically precipitates a dissociative amnestic event? Slept all that thought.
Definitely a nursing exam. I'm sure.
All right, so it's all of them. Infidelity, if somebody cheats on a spouse, that can be a stressor to that person. And it can cause an amnestic event, dissociative amnestic event. Okay? Childhood abuse, accident, trauma, death of a spouse, and the nurse. Okay? Oh, okay. Answer the following cause with the dementia type. Okay, so this is matching. We get all these correct. All right, the infectious particles called prions are with Creutzfeldt-Jacobs dementia, plaques and tangles theory, is Alzheimer's dementia, hyperkinesis with chorioform movements is Huntington's, and then hypoxic destruction of brain cells is vascular dementia. Did you good on that? Yes. A nurse is assessing a patient with dementia and observes the following behavior. The patient pauses frequently when speaking and states that thing right there when pointing to the cup of water on the bedside table. All right. So agnosia, I gave those examples where you're holding the hairbrush and you don't know what to do with it.
It's speaking.
Yeah. Yeah.
Yeah, I thought that was the meals call.
Yeah, not on the end. Yeah.
All right. The following behavior, the patient is unable to use a spoon properly during meals, despite having no difficulty holding the utensil. That's apraxia. So your patient appears backwards with mismatched pants and over their gown. So these are examples of, that's a crack suit. So being able to put on their clothes, in the correct order. I think I might do, give some better examples. So putting their clothes correctly in the right order is apraxia, so their action.
Wasn't that the answer for to the hairbrush one?
No,
If
if not.
I mean, it didn't say hairbrush, it was, that item over there.
But part of executive functions is sequencing.
Right.
So, yeah. So these are a little.
Too high.
All right, how about this one? I think you get this one. All those commercials with those cute little dogs. Shivering in the cold. All right, good job.
We had to be.
So I will make sure it's very